Well, thank you to Isakos and for putting on this webinar and for including me in it. It's a great group to be a part of. So we're going to talk about planning out an osteotomy today. And as I have no financial disclosures. As I was planning out this talk, I think I was drawn to this comparison between these two great explorers who explored the South Pole during their 1911 South Pole expedition. And I think there's an interesting comparison between the two. So Roald Amundsen, the Norwegian explorer who was ultimately successful of reaching the South Pole, planned his expedition to great lengths, taking over 50 dogs, 5 men, and 3 tons of supplies. Contrasting to that was Robert Falcon Scott's ultimately failed expedition, and on his expedition, he took over 17 men and only 1 ton of supplies. And Roald Amundsen said, "Victory awaits him who has everything in order. Luck, people will call it. But defeat is certain for him who has neglected to take the necessary precautions in time. And this is called bad luck." And I think it's an important comparison to be aware of, and it highlights the importance of detailed planning. And osteotomy certainly requires planning. So today we're going to talk about why, how, and then plan, and then just a quick slide on navigation at the end. So I think it's important to understand and to know why you're performing an osteotomy. I think that's really one of the first things that you need to do, as Tim discussed. So really the main reasons are to unload a diseased compartment for correction of a prior deformity or for condylar ligament protection. And I think that's important. And as I'm discussing specifically now, coronal plane correction, but if you're doing an osteotomy for arthritis, for osteoarthritis or wear of a compartment, there really is probably a role for overcorrecting that osteotomy even past neutral into the opposite compartment. I think in the setting of ligament or chondral protection, cartilage reconstruction, deformity correction, or in the setting of lateral compartment disease, completing your osteotomy to neutral is probably satisfactory. One of the big discussion points and decisions that you have to make when you plan an osteotomy is whether you're going to choose an opening or closing wedge osteotomy. These are really the two workhorse types of osteotomies that we have. And we're going to have some specific talks on that later. So I don't want to take their time either. But in general, when we decide between the two, the benefits of an opening osteotomy is it's only one cut, and there is flexibility in dialing in that correction. The consequence is obviously delayed healing across the osteotomy site. Similarly, closing wedge osteotomies are beneficial for a stable construct, potentially improved healing, though it can be a little bit more surgically complex. So when we go to planning out our osteotomy, these are kind of the steps that we're going to go through to plan it out. The first step, and I labeled it here step 0, is to obtain standing alignment films. And I think it's absolutely paramount that you have complete 6-foot standing alignment films to show the entire lower extremities to plan out your osteotomy. I'm surprised at the number of patients that are ultimately referred to me or who have received an initial opinion from another surgeon that did not have standing alignment films. The next step is to measure the width of the tibial plateau. And for a valgus producing osteotomy, for example, in this case, the tibia, choosing that point 62.5% across the tibial plateau from medial to lateral is desirable. And you can see that on the picture there. A good estimate is on the downslope of the lateral tibial spine. I think that's a good target. Now, again, if you're doing a femoral osteotomy or a varus producing osteotomy, probably doing it to neutral is fine. But to unload the medial compartment, for example, in this x-ray here, going to that 62.5% mark that Dr. Fujisawa described is desirable. After that, you draw a line from the center of the femur to the proposed point on the femoral side, and the same thing on the ankle side. And I'm going to try to show that in a case example, because I think it might help cement that home. So step 1 on the far left side of the screen, obtain standing alignment films. measure across the width of the tibia. As you see here, we measured it at 82 millimeters. 62.5% of that gives us 51 millimeters. And so you can see there we've measured across 51 millimeters with our desired point here on the downslope of the lateral spine. So how do we make our lines? Starting on the left side of the screen and working to the right. So first, the mechanical axis of the lower extremity from the center of the femoral head to the center of the ankle joint shows this patient is clearly in varus. This patient had come to me after 2 prior failed meniscectomies. Moving across, we draw a line from the center of the femoral head to that desired osteotomy point, and then have the lines cross as seen in the middle picture. By doing that, we create an angle between the 2 lines, which I've marked A for angle here in the 4th picture. Now, I think an important little check is if you can go back later and you can measure proximally up the femur, the width of the tibial plateau, in this case 82 millimeters, and you can measure the distance between the lines, it gives you a rough amount of opening in millimeters that your osteotomy will need. So as this patient I performed an osteotomy on, you see we've got them out of neutral. They've gone on to definitive union, and hopefully they'll do very well. Now, one of the benefits of this part of the talk is really about coronal plane correction for distal femoral and tibial osteotomies, but that same technique that I just described is useful for tibial opening wedge osteotomies, tibial closing wedge osteotomies, as well as coronal plane corrections from the distal femur. These are both well reviewed in journals of the Academy of Orthopedic Surgery in 2011 and 2018, if you would like to look at it in more detail. Now, it should be noted that you can also plan out an osteotomy for for tibial tubercle osteotomies and try to determine in advance how much medialization as well as how much distalization is necessary to correct a patient's patella alta. I use the Caton-Deschamps index when doing that, as it's not dependent on the position of the tibial tubercle. Similarly, for a closing wedge osteotomy of the tibia, as Tim Lording was just discussing, it's an approximately a 1 millimeter per 1 degree correction when you remove your wedge from the anterior cortex of the tibia. As I said, I wanted to mention at least this concept of navigation. And I think that just as in knee replacement surgery, there has become an increasing interest in utilizing navigation for osteotomy surgery as well. Currently, it is not the standard of care in my hospital or in the community in which I practice. I don't think it's the standard of care certainly in the Midwest portion of the United States. I look forward to hearing what some of the other panelists from around the world say about use of navigation in their communities. Meta-analyses have shown improvement and in mechanical access and less alteration to the tibial slope when navigation is used. They've also shown good clinical scores, but as of today, no significant difference in the clinical outcomes as compared to a conventional osteotomies. Please remember also that these studies are really limited by low level of evidence and varied and inconsistent reporting of the outcome measures. I think another really exciting opportunity here is the utility of these patient-specific cutting guides. So just as knee replacement has become more patient-specific, there's become the opportunity for patient-specific cutting guides to try to really dial in that correction for an individualized patient. Another thing that is gaining some interest, particularly in deformity correction, is the utility of 3D printed models of the bone, where you can actually go and plan your osteotomy on a 3D printed model in advance and then execute your plan in the operating room. So to try to bring this full circle, as Explorer Amundsen reported following his expedition, adventure is just bad planning. And what you don't want is an adventure like this. So this is a patient who was referred to me following an osteotomy. They were still in varus. They had a non-union. They had broken through the lateral cortex, and the patient was clinically doing poorly. So plan your osteotomy out in advance so the patient can go on to union and get on with their life and return them to doing the things that they want to do.